yes, it's very easy to say, okay, we got this data from the Institute of Medicine that suggested 100 million people were in chronic pain, but we know that there's a proclivity of addiction, and addiction is a big problem. And about 10% of the population, if you will, there's many studies that suggest anything from 9 to 16%, or even all sorts. But if we just said 10%, we'd have about 10 million Americans that would have a continuum of chronic pain in addition to addiction, whether they knew they were having the problem of addiction or not. The suggestion isn't that all opioids are bad and we've somehow demonized them. It's just that we're rationalizing which candidates might be better and at what point in their disease process opioids may be helpful and where they may not be. And how do we start picking up on where they may not be helpful? The trial of opioid therapy may be helpful, but it also will help disclose who may or may not be a good candidate. So we look at the 4 things, 4 A's. The first A is analgesia. Do you get pain relief with opioids? The second A that we want to kind of evaluate is activity. What can you do on the medication that you couldn't do otherwise? Now, we're not guided by any specific society to suggest which functional metrics we're going to choose. So we actually have to share with the patient something that looks appropriate. So sometimes I'll have patients, if they tell me, look, I feel much better on the medication, I'm thinking about enrolling in junior college, I'll say thank you, and please bring in your receipts for paying for your curriculum. Or if you're actually going to join a gym, let me know, and I'll certainly like to check on your joining of the gym. The third one is adverse events. So constipation, nausea, vomiting, itchiness or pruritus are all things that can come about from opioids. And if you're having adverse events to the therapy, certainly that doesn't suggest you're a great candidate. The last one, and the fourth is aberrancy. And aberrancy is really these behaviors that are outside of the typical limits of the arrangement for prescribing. So early prescriptions may be one. The suggestion that medications are misused or not taken as prescribed. They actually meet some of those suggestions with aberrancy, any of those types of behaviors. It may be thought that they may need to suspend therapy. And that suspension of therapy, there will be a plan detailed as to how the taper plan would take place. When you do provide the appropriate dose of opioid therapy, or you get to an appropriate dose, they do describe to you that their pain has improved. And there's actually not dysfunction, as what I mentioned earlier, worsening and exacerbated dysfunction that's even getting worse and worse, but we actually have increased function. What's interesting is that addiction enters into different aspects of medicine all the time. And in today's case, someone was talking about a patient that was very complicated, that happened to have a problem with addiction, but then